Good morning, good afternoon, everyone. I welcome you at the Nutrition Forum from the Purina Institute about the managing difficult chronic enteropathy cases. My name is Natalia Wagemans. I'm leading the Purina Institute. And today I'm very happy to welcome you at this Microbiome Forum roundtable discussion that we are going to run together with the very eminent experts from around the world. You know, I'm very delighted and proud to welcome over 3,500 participants of this event, veterinarians, veterinary students, members of healthcare teams from different countries in the world. And I'm very proud because it shows me that Purina Institute can bring a value to your professional life. It shows me that you have an interest in area of microbiome that is really very fascinating and is really very complex to put this in your practical nutrition life every day. So what I would like to share with you about the Purina Institute is probably you know already. We are not just a high science. We are on a mission to put the power of nutrition science into practice. At the Purina Institute, we are partnering with hundreds of experts around the globe who are world-known nutritionists, veterinarians, people who knows everything about animal science. What we are doing at the Purina Institute, we take all these strong breakthroughs and transforming this knowledge into the actionable and practical tools that you can use on your everyday practice. At the Purina Institute, we want to empower you as a veterinary healthcare professionals that you stay armed with unbiased, science-based nutrition information that you need every day to help your patients to be healthy and live longer. And it's not the Purina Institute only who shares this science. It's the eminent experts around the world who bring their expertise and skills together to give it to you. And I'm very happy to introduce the chairperson of this Microbiome Forum Roundtable discussion, Dr. Jan Suchadolski. You know Jan Suchadolski, and I really don't need to introduce him, but it's a great pleasure again to remind you how many different expertise skills he has. He's graduated with veterinary degree from the University of Veterinary Medicine in Vienna, Austria. He was working for several years in small animal specialty clinic. Then he returned to academia and received his PhD in veterinary microbiology from the Texas University for his work on molecular markers for the assessment of the intestinal microbiota. He's board certified in immunology by the American College of Veterinary Microbiologists. He currently serves as a professor and associate director of the GI lab. And his publications, I believe it's already more than 340 peer-reviewed manuscripts in the field of veterinary gastroenterology and the microbiome. Thank you, Jan, for putting this program together. Then the other panel member of this roundtable discussion today is Julia Fritz. She's graduated from the veterinary faculty of the Ludwig Maximilian University in Munich, Germany, and she completed her doctoral thesis about digestive physiology in herbivores at the Institute of Animal Nutrition and Dietetics. Additional qualification in nutrition advice for small animals she received in 2007. So in 2010, Julian got specializing diploma in animal nutrition and dietetics. She's diplomate of ACVCN from 2011, and also she owns a nutrition consultation service for cats and dogs near Munich in Germany. So now we are moving to Italy. Fabio Procoli. Dr. Procoli graduated from the University of Bari, Italy in 2003. So he was practicing in Italy and UK for 5 years in small animal general practice. He's rotating internship at Royal School of Veterinary Science in Edinburgh, Scotland. He has a residency in small animal internal medicine at Royal Veterinary College in London that was completed in 2012. He did 1 year research master at the same college in 2014. He's a diplomate of both American and European College of Veterinary Internal Medicine and currently he's head of internal medicine at Ospedale Veterinario Portoni Rossi Anicura in Bologna, Italy. Fabio, I hope I said it with a good Italian pronunciation. So thank you, Fabio, to being with us. Next, we move to Sweden. Dr. Linda Thoresen graduated from Swedish University of Agricultural Science. In 2001, she became a Swedish specialist in diseases of dogs and cats, and in 2007, a Swedish specialist in small animal internal medicine. 2007-2013, for this years, Linda served as a medical director at Evidensia Specialist Animal Hospital in Helsingborg, where she is combining clinical practice with GI research. Her PhD on cobalamin supplementation in dogs with chronic enteropathies and main research interest in intestinal microbiome made Linda very famous in the area of microbiome, especially when we are talking about modulation of the microbiome beyond antibiotics. And Dr. Linda Thoresen is a past president of the European Society of Comparative Gastroenterology. Thank you, Linda. And the last but not the least, Janessa Winston, doctor from North Carolina State University, which she graduated in 2011. She's rotating small animal internship and residency state training in small animal internal medicine at the same state. She's a diplomate of American College Veterinary Internal Medicine from 2015. Her PhD from the North Carolina State University in Comparative Biomedical Science with an infectious disease concentration she completed in 2019. At Ohio State University, Janessa launched the Companion Animal Fecal Bank, and I'm sure you know about that. And she's a founding member of the Companion Animal Fecal Microbiota Transplantation Consortium. And before I move this stage to Dr. Jan Suchadolski, I would like just to remind you that this is a roundtable discussion, and you're very welcome to ask questions, which you will find on your screen from the right side on the name of Slido. And with this, Jan, please, stage is yours.
Thank you so much, Natalia. Welcome, everybody. It's a pleasure to be again back here. The plan of this table round is somehow to have a continuation of our last November's forum. There's a lot of questions that come up, but also make it very practical. So the microbiome we know is important, but the microbiome is also a part of the whole organism, and addressing it is often a multimodal therapy approach. So the goal of this table round today is to have two different cases, both brought by specialists in clinical practice, in private practice. Dr. Thoresen, Linda will present one canine case that is chronic enteropathy, and then Fabio will present a second feline one. And the goal is really to afterwards build on those cases and discuss options and really also get your feedback, your questions, and how we can incorporate this into the practice. Please ask questions. There's a red button called Slido. If you click on it, you can afterwards ask questions, and we're going to try the best to incorporate them in our discussions for the next 90 minutes. So with this, Linda, I would like to invite you to present your case.
Thank you, Jan. So we'll start sharing. So this is Elliot, an intact male released in Ridgeback that was referred to me at the age of 2.5 years of age. And before I saw him, he had fever of unknown origin at 5 months of age, and also an external otitis at 6 months of age, and the otitis was a recurrent phenomena. He was diagnosed with cutaneous vasculitis of his pinna at 1.5 years of age, and it was also the case that a littermate was also diagnosed with cutaneous vasculitis. According to the dog owner, he had adverse food reactions to chicken and fish. It caused him to have a flare-up of otitis and also mild dermatitis and some mucoid feces. But now when he is referred to me, he has had flare-ups of severe lethargy and hyperexia and fever, and also soft or mucoid feces, otitis externa, plus minus uveitis since about 3 months back. This has been going on and off. And between the flare-ups, he is rather okay. He has less clinical signs, but he has marked flatulence and also has increased frequency of defecation. So he's been on the same diet for about a year now, and his frequency of defecation has increased from once daily to 3 times daily. And also this flatulence has started to occurring. And he has signs of abdominal pain. So he's uncomfortable. He has difficulties finding a relaxed position while he's resting. He's pressing his abdomen against the floor in a way that he normally doesn't do. He doesn't stretch out as well as he usually does. And for diet, when he had his fever of unknown origin and also the first otitis flare up, he was on a premium dry food diet. And now he is on 3 different types of various commercial raw food diets. And I'm not sure exactly how long he had been on the raw food diets, but at least for a year, as far as I understood. The owner had sort of forgotten when she transitioned him from the kibble diet to the raw food diets. And at the referring vet, he had multiple tests. So they had taken a CBC and serum biochemistry. The only thing they found was that he had a moderate increase of CRP during the flare-ups, but this quickly normalized. And cobalamin was in the lowest end of the reference range, but still within the normal range. Because of his many systemic manifestations, he was tested with anti-nuclear antibodies, and this test was negative, and that was done when he had a fever attack. His basal cortisol was within the reference range. Urine sample was within normal limits, and he was screened for fecal parasites on multiple occasions, and they were always negatives. Samples were also collected over a 3-day period. He had an abdominal ultrasound scan. Actually, he had 2, and both of those were suggestive of chronic enteropathy. So he had a prominent muscularis layer and some enlargement of his gastrointestinal lymph nodes. He also had an endoscopy and histopathology performed by the referring vet, which came back as moderate lymphocytic plasmacytic enteritis and also partially eosinophilic enteritis with villus atrophy, so moderate villus atrophy, moderate lymphocytic plasmacytic colitis with fibrosis, and a mild lymphocytic plasmacytic gastritis. He had tried methylprednisolone before, and that was a bit of a disaster. He became extremely lethargic. He lost 10% of his body weight in 5 days, and his diarrhea became much worse. So he had profound watery diarrhea with methylprednisolone. On physical examination, when I saw him, he was bright, alert, and responsive. He had a body condition score of 6 out of 9, and he has marked abdominal pain on palpation. He was screaming. And he also had a mild to moderate hyperpigmentation of the groin area, and his ears looked fine. There was no signs of otitis at the time. The only treatment he was on at this time point was oral cobalamin supplementation and essential fatty acids, and they were not fish-based. That was a mix of hemp, colza, and flaxseed oil. So this is the type of dog owner who tells me that she doesn't believe in commercial kibble diets. Normally, I don't start with a home-cooked diet, but we all see these dog owners and cat owners that don't believe that commercial diets are of any benefit. They really have a lot of prejudice against them, and it can be really difficult to turn that around. So in order to meet some of the dog's need and also keep the dog owner's trust in what I was doing, I changed the dog to a balanced home-cooked novel protein diet. It was a potato-based diet, and he also had some carrots and, of course, the calcium, fat, etc., and vitamins. And I added a high-dose multi-strain probiotic. And this helped to some degree. The flatulence slowly disappeared and the frequency of defecation decreased. So he was only defecating once daily. So he was back to what he had started with. But he did have a new flare-up of this lethargy, otitis, and mucoid feces, this time without fever, after 6 weeks after changing the diet. So this time I started him on cyclosporin, 5 mg per kg once daily. And because this is a rather sensitive guy and a rather stressed dog owner, I also prescribed maropitant 2 mg per kg once daily. Usually I prescribe some type of antiemetic when I prescribe cyclosporin, but I usually tell the dog owners that you're probably not going to need this, but it's good to have in case your dog have GI side effects during the first period of this treatment. But for him, we started him on both at the same time. And this was not well tolerated. He had nausea, he was standing in a praying position every day, and he also started having borborygmia again and some diarrhea. So the dog owner stopped the treatment after 10 days and then gave him a medical breaks and started again 4 days later after we had been in contact. And this time we added on Dansatron, but it didn't help. He now showed severe abdominal pain with the cyclosporin and also profound diarrhea, so he was taken off the medication again. So we gave him a medical break. He was still lethargic, and after a month, we started him on budesonide, because sometimes my experience is that if they don't tolerate regular corticosteroids, budesonide can actually be much preferred, especially for large breed dogs. But he tolerated this just as poorly as methylprednisolone. His diarrhea got worse, he became even more lethargic, and he started losing weight again. So this is where we are now. So this is a rather difficult case to treat and rather frustrating, both for the dog and the dog owner and for me as the treating veterinarian. So I will now stop sharing my slides and leave the floor for discussion.
Thank you, Linda. I think maybe one good question would be, as a starting point, is the current definitions of chronic enteropathy. I think there's a lot of confusion in literature. Is it one disease? Is it a spectrum? And that maybe also helps us to kind of have a breakdown. What are usually the first treatment trials and how we move forwards? You want to maybe start, Linda? What is your thought about chronic enteropathy, current definitions? Because I don't think there's a real approved definition. There's a lot of authors have different, mix them up a little bit.
Yeah, I think the only thing we can say for sure is it has been going on for more than 3 weeks, really. And that's the definition of chronic. And then apart from that, this is a huge group of different manifestations and different treatment options are needed. So it's not really one disease, which makes it quite difficult to find the perfect treatment every time. But the first thing is always try a diet. And normally I would have started on either a novel protein diet like I did here or a hydrolyzed protein diet. And for this case, I would have liked a hydrolyzed diet because he also has the skin problems and he also has a litter mate with skin problems. So this would be my first diet of choice in this case. And I usually like to add fiber as well. He also has some signs of colitis, which is common if you have some type of food intolerance. But because I wanted to meet the dog owner's need as well, I didn't start with a hydrolyzed diet. But otherwise, I would have started with that. That would be my first thing to do.
Mm-hmm. Fabio, what do you think about the term chronic enteropathy?
Yeah, hello, everyone. Jan, this is a topic I'm quite passionate about. I feel almost the need of rewriting the definition of chronic enteropathy. And I totally agree with what Linda just said. We are struggling because we tend to classify them classify cases based on their response to treatment retrospectively, but that's not necessarily the best way forward. And I agree with what Linda said of the huge overlap in clinical signs and if we think about also the difficulty, for example, with intestinal histopathology in helping us in distinguishing cases, so it really gets quite confusing. So my approach usually is to accept that at the moment the treatment, the response to sequential treatment trials is probably the most reliable way, and also always start, like Linda suggested, with a diet trial, like a really exclusive diet trial, focusing a lot on owner compliance. And I understand from what Linda said, maybe this wasn't probably the best owner to talk about compliance.
Before we go to Julia,
I would say that compliance is really good as long as this dog owner believes in what we're doing. So as long as, the compliance is really good as long as we can meet, sort of.
Yeah, we're a nutritionist with Julia. Before we come to Julia, maybe Janessa, what do you think about what sequential treatments? What is in literature about chronic enteropathy? Why should we start with diets?
Yeah.
And what's the next step?
Absolutely. And I think I agree with everything that's been said, thus far with, we really do need to, gastroenterologists need to sit down and start to define it a little bit better to make it less confusing for general practitioners. I usually tell our vet students and at CE events that chronic enteropathy is just the umbrella term. And then all the other, definitions of whether it's food responsive, antimicrobial responsive, immunosuppressive responsive, non-responsive, all those just fit under that umbrella. And for me, when you look at the literature, such a large percentage of them respond to diet that just like, Linda and Fabio have said, that's my go-to first. So, and a lot of times, I might not just try one diet, depending on what the individual animal's needs are. Hydrolyzed is sometimes my preference, not because I think it works better for patients, but just because in order to try a novel protein diet, you really have to get an excellent nutritional history. And Julia can talk about this more too. But sometimes clients aren't really good historians for being able to provide that. And so if I really want to try an elimination diet, I sometimes do just jump right to hydrolyzed because it can be so hard, especially with some of the boutique diets that have a lot of additional ingredients that we used to consider to be novel as now just part of those diets. I think that, that can be really hard to get that accurate history. So Julia, do you have comments on that? Because I think that's one area that a lot of practitioners struggle with of, novel protein versus hydrolyzed.
Sure, yeah. Well, to my experience, lots of these dogs are not food allergists, although they look like, because diet is also something like an umbrella term. So it's counts for everything or nothing. So in this special case, I would have probably had a very close look to what is this BARF diet look like exactly, because you have a lot of variety. You can have good qualities, let's say, in the root sector, but you can also have bad qualities with lots of tissues and let's say worse protein sources, which can lead to diarrhea, flatulences, all this. I would also always think of treats and ask for this as well, because I have seen cases where it was just the treats, the problem, and the dogs had chronic diarrhea for sometimes years, and sometimes also treated with different therapies and so on. So this would be the first thing I would do, and I always try.
Sorry, Julia, just to add on.
Yeah.
Treats is also a big umbrella term. Are there specific treats that you're asking for? Or?
Yeah, especially, like this rawhide stuff, all this chewing things of dried skin, and this in particular is always, if you find this, it can be very magic if you exclude this from the dietary plan. Yeah. And as I'm a nutritionist, of course, I try to make the patient not more ill than he might be. So I try a normal diet. So I don't go in the first step for a elimination diet if the owner agrees, but because I have all these tools. So I understand that in a clinical practice, this is probably not the easiest way. But for me, of course, I have the possibility to try to do this first. And sometimes it's a question on the relationship of protein to carbs, the fat sources. There are many details you can find. And if you put many bad things together, then you can have symptoms, maybe like in this dog at the beginning, and then it gets worse and worse. So this is what I do. And if this doesn't work, then of course I would try an elimination diet as well. It's more often a home-cooked diet in my cases, but I also use the hydrolyzed diets, of course, especially if they had, it depends on the case, if they had done lots of trials already before, or if the compliance is maybe not so good, then I try to do the solution where I expect the best answer from it and then go on further. So, yeah.
You mean you need an improvement when you change?
Yeah.
Okay.
And also, you know, if the owner says, oh, he's not tolerating this and this, like in this case, it's what does this mean? I mean, the owners always tell lots of things and they have their own impression, but sometimes it's not making sense to how the dog reacts to what they fed. So I try to find also the logic in the history, let's say, to really see or try to find out if it could be a food allergy or just a food intolerance. And this, after this, I make my decision which way I want to go.
Yeah. Perfect.
I think another important part that we didn't talk about there, Jan, is the time, right? Like how long,
exactly.
How long do you expect, you know, it take to see a response with diet? And, you know, most of the time we're recommending slow transitions, you know, over a week or so to not, you know, not disturb the GI tract any further or the gut microbiome any further and allow, you know, adjustment to the new diet. But then from there, I usually expect to see a response within 2 weeks for the GI signs. Now, Linda's case is a little more complicated because there's also skin signs, otitis, et cetera. But for the GI component, I really expect to see that in that short window. And the literature, you know, does seem to support that. What about in everyone's experience?
Can I?
Yep, Julia, go ahead.
I would expect it even faster.
Yeah.
And we have, there was a study done in Munich, and it was about 5 to 7 days, or sometimes even a little bit less in the GI signs. And it was about 2 weeks in the dermatological signs. And I would also do the transition quite fast, actually, because if my suspicion is that this food is making a problem, then I don't want to wait any longer. So I promote a faster transition in these cases, actually.
And how long? So let's go back a little step. So we know diet is important. And so the question comes up, how aggressively or how many diet trials should we do, correct? Because I think there's a lot of new information that if the first diet doesn't work, we should have second diet and so on. So you usually say every 2 weeks, you would say, if you go to history, obviously, and then you try a new diet and you would wait 2 weeks on average. Is this correct?
Yeah, it also depends on how the dog reacts. If he's not responding anyway, then 2 weeks would be, I guess, a good time left to wait for. But yeah, I wouldn't wait 8 weeks or 6 weeks. If there's at least a little improvement, or the improvement I'm expecting.
Perfect.
The other part that's hard, though, is whether they'll eat the diet, right? So sometimes even right at the beginning, we'll send them home with, you know, a handful of diets to see what they even want to consume. Because sometimes I am limited. You know, not all of our owners in the U.S. can go to a home cooked diet right away, or they just don't prefer that. They rather use the commercial diets. And in those cases, you know, we have many options then that we can send home and see what the animal prefers to eat. And a lot of times that's how I guide what diet we try, because, you know, the compliance piece on the patient's part is such a huge component of that.
But I think
can I add something there? Yeah,
sure.
We do something similar. We do like a taste trial sometimes. So we have the common commercial diets, the premium veterinary diets, so the typical different hybridized diets, but also single protein diets. And we let the dog sniff on the different diets. And also you can often see what diet they seem to find most attractive. And that is usually very good for the client, because they are much more interested in buying this bag of food than they've already tried. Often when they see me, they've tried so many different diets, so they're not very interested in, and often they say, I'm not going to change the diet. Whatever you say, I'm not going to change the diet because I'm happy with the diet. Okay, but your dog is not doing fine. No, but I'm not going to change the diet because it's not the diet, which of course they can't know that. But then if the animal shows interest in diet X, then it's much easier to send them home with that. So we found that beneficial. And actually, even for the cats that often don't like to eat when the vet is looking at it, you can often tell by the intensity it's sniffing on the diet if it seems to be interesting or not. So I think that's one advice to take home to actually help with compliance for the dog owner or cat owner as well.
Let's stay a little bit on the diet, because I think plenty of studies have shown that 70 to 80% of animals, dogs or cats, are going to respond to dietary change, correct? Before we move on to further diagnostics we're going to discuss in a second. But Julia, for you, so you said, okay, you have the time as a nutritionist to more history, but for a practitioner, what would be the first thing you will start with? What would you look at a diet, and how you say, what would your first step be on the invitation you get from the owners, how to change as a first diet trial?
Okay. Well, first of all, I would really ask for the treats and chewing stuff the animal might get to eliminate all this just in case, because we will have a quick response. So usually the compliance is quite good if you explain it to the owner why it's important to do this. Then, of course, I think you have to have a little idea, at least, of the diet he's getting right now. If it's not possible, maybe you can ask someone, but then you can choose a diet where you can trust. Maybe, so it can be a commercial diet, it can be a GI diet, it can be a hydrolyzed diet, depends on what you want to know. So if the question is if this is food responsive, then you have to take something what you can rely on. So it depends on the situation. And then you see how the dog reacts. So if your first choice would be a hydrolyzed diet, then it's fine, you know, okay, the dog's doing better. And then you can do a normal, maybe commercial diet to see if it's the hydrolyzed part which was important, or if it's just the other type of food which was important, especially if in these raw diets, I mean, it's a mess sometimes what you find on the market. So it's really, I think we have to be careful if we think in these boxes. Barf is always barf and home diet is always this and hydrolyzed, because there are lots of different relationships and all this. We nutritionists, we love this, we find often stuff, but of course it's for a practitioner not so easy. So I would recommend to look in the history if you think also if there was maybe severe diarrhea before, something where you think, oh, it could be an allergy, or like in this case, you have the brother, I think, who had the skin problems as well. So there might be, and then decide which way you go, allergy first or just another food first, and you can always switch. So does this make sense? Or
how about fiber? How do you kind of, we know that fiber is important. How do you select, for example, a fiber-enriched diet? Is something that you should consider as a first choice, maybe?
It depends also, because when you have a wet food, a regular wet food, just normal, not a vet diet, normal commercial vet food, usually there's not much fiber in this. And some sensitive dogs can have typical signs of, let's say, chronic diarrhea, not very severe, but still present. Typically in the evening, it's worse than in the morning. That would be a typical sign for just a normal food responsive problem. And in these cases, it would be a good idea to just add some fiber. It can be psyllium, it can be cellulose. And moreover, the owner doesn't have to change his food. So you can wait a week and you try and to see how the dog responds. And often enough, it's solved, the problem. Then if you have a dry food, usually you have already fiber content in it, if it's a good diet. So here as well, do you know the company? Do you maybe know the food? What is your experience? Can you rely on this or not? And if not, you would take another diet which you trust more to find out. So you don't need to go for fiber in the first instance. It depends if you had fiber before or not. And in a raw diet, it would be the same. The people feed vegetables and they think, oh, this is fiber, but vegetables, sometimes it's cut in little pieces, the dog doesn't chew. And, you know, there's quite a lot of problems with vegetables as well. So it's not reliable enough. And does it, yeah.
Julia, if I can ask regarding fiber, one of the problems I find, I don't know what the other things, is on extrapolating the amount of total fiber from a commercial diet, because it's not usually stated, and so some people think they actually are using a diet with a adequate amount, but then you find out that actually that's not the case, and they don't always tell you the source of the fiber, which I understand has a huge implication on efficacy.
Yeah,
Is that
it's correct, yeah, and it's also an analytical problem because the declaration, you just have the crude fiber fraction and doesn't represent the whole fiber in a diet. So it's not that easy to have a look at, but you can always add fiber to no matter what diet if you want to try if it helps. So really, no matter what diet you have.
Yeah.
And of course, it makes a difference if you have more fermentable fiber, which will have a prebiotic effect, or if you have fibers like cellulose or psyllium, which has more water binding effect and a more cosmetic effect.
Yeah, but luckily there's a lot of fiber-enriched diets that are nowadays
yes,
fiber-enriched and so on. Yeah. Okay, we have to move on for the next step. So diet is obviously the most important one, which is complicated, but I think the combination of fiber, digestibility, I think we learned a lot the last few years. But let's assume you are now pretty much, you tried several fibers and it's the several different diets, no improvements. What is the next step? At which step are you thinking about biopsies? Are you thinking about antibiotics? Fabio, maybe you?
Yeah, so that's a good question. I changed the way what I do now, because in the past probably endoscopy and histopath would have been my next step. And I'm going to be honest and say that after the hydrolyzed diet trial, I was also for habit moving on to histopath. Now definitely try several diet types, and the next step, it's more looking to microbiome, sort of like related treatments before considering endoscopy, histopath. Because my concern is, especially when the dog is young, and so the likelihood of having a severe inflammatory chronic enteropathy is rather small, then I would rather wait. Because once you do, what I feel sometimes happens is once you do endoscopy and biopsies, you're bound to find some inflammatory changes, which we now know are not so important compared to the structural changes, so changes of the villi or lacteals or crypts. And then it's almost like a compulsion to immunosuppress a young patient. So I've changed the way I approach these cases. So my next approach will probably be a microbiome-related treatment modality, whether it's an FMT or trying the immunomodulation effect of probiotics. But I now wait much longer than I used to before moving on to obviously looking at the clinical picture. So what the dog is telling me. But in the majority of young dogs, especially with large bowel diarrhea, but otherwise clinically okay and stable, I definitely wait before.
Okay. So Linda, this dog had, I think, lymphocytic plasmacytic enteritis, correct?
Yes.
What is your interpretation of that, and what do we make sense of biopsies nowadays of histology?
Well, yeah, that's very good. That's the $1 million question, actually. But this is the most common change we find. I mean, there has been shown many years ago in Karanali's study that there's no relation to how they respond to what we do correlating to the degree of inflammation there is. This dog had moderate villus atrophy, which tells me that this has been going on for some time. And also the borderline cobalamin that was just above the limit. So those two markers would tell me that this has been going on for some time. But it doesn't say that it necessarily needs to be immunosuppressed. He does have some degree of fibrosis, which also tells me that this has been going on for some time, but it still doesn't tell me which treatment I'm going to choose for him. Mm-hmm. But one good thing with biopsies is that you can also use it to think or to say that, okay, we haven't found anything that tells us this dog has a neoplastic disease. It could still be there further, so in the jejunum, which we don't reach very well with endoscopies, especially in the large breed dogs, but that's one reason also to perform an endoscopy. And I think in this case, they did it because they felt a bit desperate. So they wanted to have a look there because he didn't have that much of a GI sign. He did develop more GI signs later, but at this time point he had so many confusing signs. But as Fabio said, you often find these changes, and you can find these changes even in dogs that don't have severe problems. And you can also have dogs with really severe problems where the histopathology comes back completely normal and the dog still has a lot of signs of chronic enteropathy. So yeah, the value of biopsies, we like to have them, but actually it doesn't tell us always very much.
Okay. In this case, why do you think this dog wasn't on prednisone cyclosporin? Was there maybe some fungal disease, or had you concerns?
No, well, I didn't expect it to be some fungal disease. We didn't see anything of that in the biopsies. And also some dogs do not respond as other dogs do. So most dogs respond to corticosteroids that you immunosuppress, or maybe not immunosuppress, but give anti-inflammatory doses. But there are some that don't tolerate it well at all. And this is one of those dogs that tolerate corticosteroids really poorly. And sometimes they actually got worse from it. So I don't think it's a fungal disease, because in the end, he did respond to another type of immunosuppression, but not corticosteroids and not cyclosporin.
Yeah. So from the workup, so we know that diet is number one, right? So we have multiple diet trials, and if the patient is stable, the decision is, we talked about biopsies, at which point are you using antibiotics versus steroids? At which part of the treatment, maybe Janessa and Fabio?
Yeah, I guess I would say I'm not using antibiotics. So I was trained during vet school to reach for metronidazole, if nothing else, if there's an infectious cause that we might be missing, or the anti-inflammatory effects. But we have building evidence in this area that actually can disturb the microbiome further, right? So I basically describe metronidazole as a nuclear weapon against every microorganism in the GI tract. And when we give it, it wipes everything out, including the good guys that are trying to, help in this really inflammatory environment. And so I'm not reaching for antimicrobials in these cases. And, I do get the cases that are referred in that are on Tylosin, or have, they've seen a partial response with Tylen. And I guess, in some patients, maybe that can make a difference, but my concern for them is antimicrobial resistance over time. And that impacts the current patient, but also all of us, right? And so I think that, I'm not reaching for that in my toolbox for chronic enteropathy. And I think usually if I see an animal that has a response, what that indicates to me is what Fabio mentioned, which is that modulation of the microbiome and a different methodology may actually work just as well. And so I think that's where, my clinical practice has changed, given, even work like, from Linda, from her group, which I'm sure we'll talk about here at some point, but looking at fecal transplant in these guys much sooner, that treatment for me used to be as a last resort after I've tried everything, and then I'm going to try fecal transplant. But I'm starting to incorporate it sooner in these chronic enteropathy cases, especially in patients that get referred in to me and they've had 2 or 3 rounds of metro, and then they've tried Tylen. And at this point, I don't know if the diarrhea is because of chronic enteropathy or because they have such a bad dysbiosis from all their antimicrobials that they've been exposed to.
Yeah, Fabio, I know that you also kind of shifted your approach to what is your experience with antibiotics and Tylosin specifically?
Yeah, so I mean, my take on Tylosin and other antimicrobial, for example, metronidazole, which unfortunately is still quite abused in general practice, especially in Italy, is that I'm not debating whether they will resolve clinical signs. That's actually the problem, is that some of these dogs will get better, but when you actually follow them long term, and there was a beautiful study from Karin's Hallensbach. I remember one of the final year students while I was there at the RVC. They actually followed up all these cases after several years, and none of the antibiotic responsive dogs was actually in clinical remission. So they were all not refractory, so non-responsive chronic enteropathy cases. And this is what I feel sometimes we forget, is we reach for the short, for the quick solution without looking at the long-term picture. And like Janessa just said, the long-term chronic effect of antimicrobials on the microbiome can actually then lead to a serious problem. Maybe we can see it in the next case as well. But so I
Yeah.
definitely, antibiotic for me is the last resort. I can tell you the only cases where I consider are granulomatous colitis of boxers and French bulldogs, all those cases of severe mucosal dysbiosis. But I use them for a short period of time while I'm looking at other ways of improving the intestinal homeostasis. I do not use them long term. Absolutely.
Yeah.
So one thing that sometimes comes up when I talk to referring veterinarians is they've submitted a diarrhea PCR panel on these cases, and they come up positive with Clostridium perfringens, and they're calling me to ask what to do, or they say, the clinical signs are better on Metro. Is it related to this? And I think probably all of us experience that, and I think this is a complex issue. But I think when I was in vet school, I learned that C. perfringens was a pathogen, and we should be targeting it and treating it. But I think as we start to learn more and we see how common it is in normal dogs and normal healthy dogs, that really it's acting in an opportunistic fashion. So when you have this really unhealthy environment in the intestine, it's going to shift the microbiome, and C. perfringens is part of that. And so having it come up positive on a patient with diarrhea, I don't really know what to make of that. And I'm curious how everyone else, on the call handles that.
Maybe I can add something to it, because we have some studies together with Munich in chronic and acute diarrhea, and perfringens is often increased in acute diarrhea, but it goes away completely by itself. So it decreases in a normal range and without any specific intervention, and it's always there. So if you find one, it's just normal flora. We cannot really get rid of it. I don't think there's a reason. There's no correlation. Again, I think we talked today a little bit about it. That's in the end, we don't have any good predictors, correct? There's very, very few pathogens out there that need treatments. Everything else is kind of related between the GI tract and the microbiome. Dysbiosis quite often, and ultimately it is a very clear sequential treatment approach with diet first and so on. So that's important. Maybe we need to kind of move on maybe to the second case. So Linda, you have a few slides.
There is a very interesting question, Jan, and maybe we should clarify that before moving to the next case. So what is the difference between food allergy and food intolerance?
Okay, maybe that's for Julia. That's probably the first question.
But food allergies is related to the immune system, which means the dog would react in any case when he would have contact to the food he's allergic to. Because sometimes we have cases where the owner says, oh, he tolerates it when it's raw, but he doesn't tolerate it when it's cooked or something like this. So this can't be an allergy. And food intolerance is everything else. It can be a bad relationship of protein to carbs, no carbs, the wrong fiber, no fiber, the wrong composition, everything else. So to my experience, we have lots of cases referred with food allergy suspicion, and maybe I haven't counted it, but I would say it's maybe 10% or even less, which are really food allergic related to the immune system. So it's always a good idea to really look deeper what else there could be. But I know it's difficult for clinicians to do this. So we should work together more.
I think it's incorporating nutritionists earlier in the consult would be something very useful.
Very funny as well.
Okay. Linda, maybe you wanna.
So Fabio actually has that. So if you start sharing your screen, Fabio, we will see. So after Elliot got even worse, and he was so lethargic, so the dog owner said that, okay, we must do something now because otherwise we're going to put him to sleep. So then I started him on mycophenolate, 500 mg tablets, 12 mg per kg, once daily, and that caused a marked improvement. He became much more active. He started playing again, and he had no signs of abdominal pain, which was great. But life is not very easy many times as a clinician. So of course, after a few months, he had thrombocytopenia. Wasn't really severe, but his levels just continued to drop. So then I had to decrease the dose, and I had already shifted him to every other day. So I decreased the dose even further, and then he started having new clinical signs. So he had recurrence of the clinical signs, and then we decided to try fecal microbiota transplantation, which he responded really nicely to. especially after the third treatment, but he did respond to the second as well. And he did so well for about 3 to 4 months, and then he relapsed slightly, not at all to the same degree as before. So he was still on a low dose of mycophenolate, and after 3 to 4 months, I gave him a new FMT, just one treatment this time, and he responded really nicely to that. So he's doing really well at the time on a low dose of mycophenolate, and we probably will have to give him FMTs a few times per year to keep his microbiota under control and also the metabolome. And if you move forward, yeah, we have just had this paper accepted on the clinical effects of fecal microbiota transplantation as adjunctive therapy in dogs with chronic enteropathy. I should say that Elliot is not part of this study. He's part of another study that hasn't been published yet, that is still going on. But so now we have more evidence on the use of FMT in dogs with chronic enteropathies. This is in press. So you can't read it yet, but you will be able to read it online very soon. And this is something we have been working on for quite some time. So the evidence is increasing that we can use fecal microbiota transplantation in dogs with chronic enteropathies.
Yeah. I think there's going to be a lot of questions with FMT. Let's wait a little bit, because I think, Fabio, you're also going to, in your case, have it incorporated, so we can probably speak about why is there a reason for multiple FMTs? I mean, there's a lot of new information coming too, that FMTs is a nice adjunct treatment, but important to consider as an adjunct, and often repeated FMTs could be important, correct? So maybe, Fabio, want to start with your case?
Yes, so here is my case. As you probably know already from last year, I'm a crazy cat person, so vet as well. So of course I was going to show a feline cases. So this is actually a recent case and quite a difficult one, so pertinent for the topic of this evening. So this is Frodo. He's a 2-year-old male neuter Sphinx. He actually was referred to us for chronic mixed bowel diarrhea, mostly large intestinal, so also hematochezia, tenesmus, and mucus. Really rarely vomiting, and as you can see from the picture, poor body condition and also abdominal bloating, and the owner had a perception lately of increased appetite, so that's why I mentioned perceived polyphagia. And he lives indoor with 2 other Sphinx and 1 dog, and none of them has clinical signs or GI signs. I mean, the workup done before he was brought to our attention included ruling out retroviral diseases. Of course, they did some fecal test for helminths and protozoa, and interestingly, the Giardia SNAP test was positive. So Frodo was treated with albendazole, and clinical signs did not improve, despite the SNAP. The recheck SNAP was actually negative. Then he tried a few diet trials, exactly like we suggested and recommend to do this evening. So first, a highly digestible, low residue diet, both wet and dry. And I know Julia asked me these questions earlier, so I'm going to say before I forget, he was fed dry food ad libitum, because it's important, like Julia reminded me, to ask clients about the habits of eating, especially of cats. So he has dry food ad libitum and wet food offered 3 times a day. He was then trialed on a hydrolyzed diet, again, dry and wet, but clinical signs did not improve. So the referring vet reached out for metronidazole and omeprazole for the vomiting episodes. And indeed, he did get slightly better, especially in terms of his bloating and his fecal consistency, and his vomiting resolved. But as you can see, the owner was not satisfied, so he was brought to us. And before coming to us, he tried also the multi-strain high-dose probiotics. So this is the workup we did when it was presented to us. We did some blood work, and here you see the key findings. So interestingly, he had a mild to moderate neutrophilia. He had a mild to moderate polyclonal gammopathy, and on the serum biochemistry, he had a slight increase of ALP and a slightly decreased cholesterol. Now, the abdominal ultrasound findings are quite surprising. I mean, I'm honest, I did not expect to see such significant changes on ultrasound, especially the lymphadenopathy, the jejunal colic lymphadenopathy. They were enlarged, they were hypoechoic, which are findings that we sometimes see with severe inflammatory disease, sometimes even low-grade lymphoma in cats. And also his liver, his spleen were enlarged, abnormal on ultrasound. So not exactly what I expected. So we decided to FNA liver and spleen. Unfortunately, there was no signs of infiltrative disease. And as we continue to work up the case, we discovered a severely decreased serum cobalamin. Of course, we were bound to rule out EPI, although rare, it exists in cats as well. So that was excluded. And we also ruled out Trichomonas fetus with PCR. Okay. And so what we decided to do first was to try for, again, a dietary trial, exactly like we said earlier on today. So we reached for a type of diet he had never tried before, so a fiber-enriched diet. We supplemented his cobalamin through the oral route, and we continued his multi-strain high-dose probiotics. And he did improve 1 month after. I mean, the fecal consistency did improve slightly. He gained 200 grams, but his ultrasound findings were not improved, and the owner wasn't very satisfied. So we decided, given the severity of these findings, we decided to move on to gastrointestinal endoscopy and histobiopsy and histopath. And the main findings related to duodenal and colonic neutrophilic inflammation, quite moderate inflammation, with a mild lymphocytic, lymphoplasmacytic infiltration. So what we decided to do, because we started to be concerned about granulomatous diseases, for example, FIP, so we requested coronavirus immunohistochemistry, which was negative. We were concerned about perhaps, again, a granulomatous bacterial infection, so we performed FISH, which indeed was positive for small cluster of different bacteria within the neutrophilic infiltrates. And Campylobacter coli caught our attention, and you know, there is some literature relating C. coli with neutrophilic enteritis in cats, so not convincingly, you probably guessed it from what I said earlier on, we decided to try a very short trial with Tylosin. We didn't want to use erythromycin. We didn't want to use quinolones for the risk of antibiotic resistance. So we thought 1 week of Tylosin, let's see if something changes, but no further improvement was noted. So we discontinued Tylosin. And what we decided to do was to look into, after 3 weeks from the end of the Tylosin, was to look into the microbiota situation of Frodo. And this is a dysbiosis index, so qPCR. You will see the index was quite markedly increased, indicating a shift from what you would normally see in the microbiota of healthy cats. And you can see how severely decreased some key bacterial groups were, especially Clostridium iranonis. And if you pair that with what I said earlier on, so the severe decrease of cobalamin, I take this as, you know, alarm bells that these cats, despite his young age, he's actually suffering from quite a severe chronic enteropathy. And I guess we can open, Jan, the discussion to the floor before I show you what I did next.
Sure. So why, maybe explain, why would you think that those two markers are markers of severity, or severity in a sense of, can you maybe explain a little more about that?
Yes, because we tend to see, as you can see, I mean, from the picture I also showing here from the graph, I'm seeing, when we see severe hypocobalaminemia, we presume there is already quite significant malabsorption. So there is an underlying disease to consider. We don't see this commonly in cats or dogs, for that matter, with mild disease. So it's already like a marker of severity. And if you look at the dysbiosis index graph you see on this slide, we tend to see such severe DI with chronic enteropathies, sometimes also with small intestinal lymphoma, or with chronic antibiotic usage, which we know will cause a severe shift in the microbiome. So together, I think these are two markers of severe intestinal disease, I think. I don't know if my...
Yeah, Linda, I think you also have, since you're a cobalamin expert and also FMT experts, how do you look at those? What dysbiosis means nowadays, what cobalamin means nowadays for the treatments? Is it a marker for specific treatment, a marker for chronicity, or how do you see those?
Well, if I agree with Fabio that the very low unmeasurable cobalamin tells us that this is more severe disease, more marked disease than the regular case, and especially considering this cat's young age, because in an elderly cat, we quite often see a lower cobalamin without having that much of clinical signs. Usually they have weight loss and but not that much else, or some mild vomiting. But a young cat, he was 3 years of age, right?
2.5, yeah.
2.5, yeah. With that low cobalamin, that really tells me that this is severe disease with severe malabsorption. And I agree also that with this large shift of dysbiosis index, this tells us that he is very far from the normal microbiome of a healthy animal. And even if we don't have any studies yet looking specifically at that, my clinical impression is that the ones with really severe dysbiosis index are the more difficult to treat ones, the ones with more severe disease. But the only thing here is that he did have a week of antibiotics 3 weeks before that, and that can still have an effect here, even if it can be quicker to resolve. I wouldn't totally rely on that. It would be the same 1 month later. So that's the sort of red herring here. But otherwise, I totally agree with Fabio that this very high dysbiosis index and unmeasurable cobalamin really tells us that this is more severe, pronounced disease that has been going on for some time.
Mm-hmm. So what would you kind of, I mean, I think the question of those severe cases, what is the expectations? Is the expectation is that we have a specific treatment that is a cure? Is it expectation that we're going to have long-term treatment? Would be the kind of, I think in the Fabio, that's what you're kind of trying to come on. Yes. What is the next step in this case? So maybe you can potentially show us the next slides, and then we can come back to the discussions.
Absolutely. Mm-hmm. Absolutely. So this is what we did. So I reached out to my cats. They are my fecal microbiota donors. So that's the dysbiosis index, which I already disclosed last year. And so we did an FMT, actually 2 FMTs, 2 weeks apart. That's what we started doing in our hospital, as a standard FMT approach. And this is actually his fecal consistency as of now. So, I mean, you will appreciate an improvement. The owner also reports an improvement in overall energy levels. She thinks that Frodo is going back to his usual self, being more playful, more active. And I know that Linda often talks about his canine cohort, where often clients report also this unexpected clinical improvements after FMT. So that's what the owner said. But again, it's still far from what you would expect normal. But my wonder is, looking at what we were saying just earlier on, looking at the dysbiosis index, if that was true, so I take what Linda said about the possibility that tyrosine is still lingering. But if that's his dysbiosis index, could we expect something better than this with FMT, considering what I just said about the likely severe underlying disease? And so I now looking at those markers of severity as a way of informing my clients that perhaps cure will not be a realistic target, but perhaps the clinical improvements, improving of the quality of life, would probably be more reasonable. And that's what we did with Frodo as well. And we waiting on his dysbiosis index post FMT to see perhaps if to these clinical improvements, we also had a microbiome improvement.
Yeah, I think maybe just one comment and then following a question, but we know that antibiotics, especially in cats, antibiotics have a very severe impact on the microbiome. And in cats, the effect is long lasting. But from the experience of clinical studies we have is that antibiotics can induce long-lasting dysbiosis, but usually the dysbiosis index would go down a little bit. It could be still dysbiotic, but very unlikely to be as extreme high if it's just antibiotic 3 weeks past. So I think from our experiences, I would definitely think there's also a component of GI disease there. But again, the main, I think, point of that is that even with FMT and markers like cobalamin, obviously you're going to supplement for sure.
Yeah.
But the question is always, I think we are learning more and more if those markers are severe, then it seems to be prognostically that this is a long-term treatment, correct? And I think, Linda, your FMT study coming back to it kind of shows that most animals are going to relapse again. They get clinically better, correct? But then the expectations would be that we're probably not going to be able to fix that. Maybe you can talk a little bit about that.
Yeah. And what I usually tell my dog and cat owners that come with long-standing disease and also markers of severe disease, then that this disease is not going to go away. Hopefully we can suppress it and we can improve the microbiome and we can make things better. So we can improve the quality of life, but they shouldn't expect a cure. We're not just going to throw some pills or a diet at it and everything will be fine. And so we do have the ones that respond really well to diet, of course, but then some of them will relapse and be more difficult to treat the second time as the disease seems to progress. So I think that's a very important thing to tell the dog owners and cat owners, that don't have realistic expectations of this. And even the ones that respond super nice to FMT, we tell them that we don't know yet which of the ones that will relapse, but it's quite common that we will have to give a top-up after 3 to 4 months. And some of them need to be on, well, not monthly. I did have one on monthly, but that was a horrible case that we couldn't manage him for a very long time. But usually for the ones that we need to top up, we do it every 3rd or every 4th month or like twice yearly. But then we also have some dogs that we gave a series of FMTs, 3 different treatments, and they have been fine for 3 to 4 years. So they have been able to decrease the corticosteroids. They haven't had severe flare-ups, and it just seemed to sort of change the negative process for them, so they could be kept on the maintenance treatment they were on and even lower that. So for some dogs, they don't seem to be able to repeat it. And as for yet, we don't know which ones. I believe that the ones with the most severe dysbiosis index at the start, baseline, are the ones that will relapse the quicker. Our current research where we do a prospective study where we follow them up over time after FMT indicates that that's the case, and that was also true in the retrospective study. But I think it's important that they have realistic expectations that this is a lifelong disease for most of these animals.
Mm-hmm. And ultimately multimodal with diets and other conditions, correct? Not just one therapeutic approach.
I think that that's so key in the initial owner communication, right? Because they're expecting, look at my patient, write a prescription, and things are going to get better. Like that's what they want out of the visits. And I think setting that up at that initial evaluation of that, really our goal is going to be to try and minimize clinical signs to improve quality of life is important, because I have some owners that are caught up on the cosmetic appearance of the feces, but the dog's gained weight, doing great, has energy. And I'm like, okay, so is a 4 or 5 or 6, I don't know, that matters if we're achieving, overall health and whatnot. So I think that is a conversation to have with them too, of what those expectations even are for us of, do you ever expect them to get back to totally normal or not? Some dogs we can achieve that, but not all of them.
Yeah, and Jan, there are a couple of questions around dysbiosis index, and I know that you talk about that already, but to make it maybe a little bit more clear, when do you do that, before or after diet change, and can you use it as a monitoring the result of the treatment?
Yeah, I'm also, we, like Fabio and Linda already discussed, I think what we're discovering now that dysbiosis itself is an assessment tool, kind of. It's not necessarily, again, it's not going to predict a specific treatment. But often we discover now in some studies that most likely once we detect dysbiosis, at least with the index, that it's already an advanced stage in most cases, if you can exclude antibiotic usage. if you have antibiotic-induced dysbiosis, usually FMT brings them back pretty well, and usually clinical signs disappear. But once in chronic cases, once dysbiosis increases, it is kind of a prognostic indicator for long-term in most cases, not saying everybody. And so in the end, I think discovering now that many of those markers are assessment tool markers that can be incorporated for assessing the stage of the GI tract, like helping the conservative the owner, what his expectations. But none of those markers is truly a specific treatment approach because we put them in together with history and so on. And I think for me, like when you see Linda's studies, that we still see dogs that are clinically better, but when you check the dysbiosis index, the dysbiosis comes back again, and you can pretty much predict those dogs going to relapse sooner or later, correct, Linda? So I think that's what we need to understand. It's an assessment tool. It is not a specific treatment.
I think that's one of the things that from a clinician perspective, why these can be so frustrating, right? Because we do a large diagnostic workups that are time consuming and expensive. And in reality, we are really trying to rule things out. We're trying to figure out, make sure that there's not infectious disease that we need to target. We're trying to figure out whether there's underlying neoplasia that would potentially change our treatment course. But once we've ruled out those things, then we are stuck in this inflammatory chronic enteropathy state. And it doesn't matter if we have, all the diagnostics, we have histopath, all that. It really comes down to the importance of really controlled treatment trials to figure out what's going to work for those patients. And I think from the clinician perspective, for me, that sometimes can be really frustrating. I do hope that, people on this call and others, that are working on this, that we continue to try to, to figure out ways to have predictions of who's going to respond to what. I think all of us in some component on this call are working to try to do that. But at this stage, we don't have that. And I think that conversation also is helpful to have with owners, because they do expect that when you get the histopath back, that all of a sudden it's the answer, and now you know what to do. And in those cases, I'm like, well, I'm just as good to ask my magic 8-ball, like what should I do next as a prediction, right? So expectations are important to set up.
Yeah, but I think that's also, sorry, just one, maybe I think what we kind of probably over the last few years really going to discover that we have to focus on is early detection of abnormal, when the GI tract starts to become abnormal. And so the early intervention, and maybe even just a dietary change, we don't know what's the best one, but the sooner we realize that chronic signs come, and most likely there is a chronic process, we don't want to wait months or years until we do a treatment kind of, and what the best treatment is, this diet is probably a good starting point, I would think. But I think that's probably the future. It's this earlier detection of when the GI tract microbiome starts to shift. But those are, again, markers of a chronic process, and the sooner we start, the probably better. And again, Julia, that's why diets probably is always going to be the number one. And I think
I just wanted also to say, to my experience, the longer the animal is showing clinical signs, the more difficult is it to manage with diet. So it's easier with patients who don't have a history of 2 years of whatever problems. So it does really make sense to look at the diet right at the beginning, if it's possible, than to wait all the treatments, because there are chances you might find good solutions. And sometimes I think you have really the diet or the food is sometimes the reason for the problems, or can be the reason, and sometimes so it's the treatment then, if you want. And sometimes I think, like in the case of Fabio, it can only be a management, maybe to look deeper. Maybe you can adjust some little pieces, but this case looks too severe to say, or it might be a dietary problem. I don't think.
One question came up is FMT in patients who don't have diarrhea, but they have, for example, dysbiosis plus regurgitation or vomiting. Do you see any benefits in those cases to try FMT?
I've seen an improvement in patients in even just abdominal cramping and pain, right? So no diarrhea, no weight loss. And we've tried FMT and it's helped. And kind of the cases that we end up putting into the category of IBS, irritable bowel syndrome, where it's a stressed animal who's high anxiety, who might have flare-ups and whatnot. I'm reaching for microbial interventions much sooner in those cases than I did previously. And they don't always have to have diarrhea.
Mm-hmm.
Yeah, I totally agree with that. So the study that is now accepted and still soon will be available online. Not all of those dogs had diarrhea, far from it. So some of them had just abdominal pain, some of them had bloating, some of them had vomiting or pica, etc. So yes, you don't have to have diarrhea to respond to FMT. And what the dog owners liked the most was the increased energy level that these dogs experienced. That was the most common change. So increased the energy level and also improved fecal quality. And if we look in human medicine, then that's been shown too after FMT in both irritable bowel syndrome and in inflammatory bowel disease, that increased quality of life has been reported afterwards that lasts for up to 6 months. And that could have something to do with the tryptophan metabolism on the gut-brain axis, because we will affect the metabolome and also the microbiome. And in studies and review papers in people, then the GI signs are not always the worst problem. So the diarrhea may not be the worst, but actually the fatigue and the lack of energy and the pain is what causes the lowest quality of life. And I think that's a very important message to stress for dog owners, like Janessa said before, that yeah, the poop is not perfect, but the dog has no signs of abdominal pain on palpation. The dog is playful, the dog is active. So if the stool is not perfect, that's not the end of the world. The quality of life can be good for this patient, even if we don't score a 2 out of 7 on the Purina fecal scoring chart.
Yeah, and there is a question, it seems again, about dysbiosis, Jan, to you. So if you have a patient with the chronic enteropathy with multiple drugs on board, many times including antibiotics, do you tend to proceed with dysbiosis index at the initial and then subsequent visit?
Yeah, I think if you have on antibiotics, I would wait for sure. I mean, at least 2 to 4 weeks. It depends on the history of an animal too. I think if the history is very clear and a young animal antibiotic-induced dysbiosis, then sometimes it can help with deciding if FMT might be a good approach, right, Fabi? You have some experiences there. And then afterwards, probably just after 1 month, to see if the dysbiosis resolved. So sometimes the follow-up sample can be helpful if the antibiotic was the primary problem and dysbiosis is normal, which should happen. But if the dysbiosis usually comes back after 4 to 8 weeks, then we can pretty much be sure that there is an underlying GI component to that needs to be treated. So again, it's a multimodal. There's a lot of damage in the GI tract, and that's why it's such a frustrating disease. And I think the treatment approach is multimodal. We talked about diets. Are there any supplements that you routinely use in treatment of chronic enteropathy on top of diets?
You mean except of fibers and cobalamin?
Yeah, and
that's cobalamin, the two which makes sense. Otherwise,
I think what's maybe probiotics, or I think that's other supplements that are. Mm-hmm.
I can start if you guys want. I mean, sure. on probiotics, I have my own take on probiotics, and I don't know what the other experience is, but there are some patients that I really see benefit from probiotic treatment. So adding on probiotic to the treatment protocol, and when I try to actually take them off, they will relapse. Yeah. So there are, it's very difficult to predict which cases they are. So, and that's what I meant earlier on. So I see probiotic as a treatment tool in my sequential order to consider. I tend not to add them onto diet in every case because there are also costs considerations, and if I want to see whether it's a food responsive case, I like to just try diets, but sometimes it's my second sort of like a trial, and there are some cases that really benefit from it.
So first diets, then a probiotic trial, correct?
Yes.
Okay.
I do both at the same time. For some animals, if we want to speed up the process as quick as possible, depending on how long they have been ill for. But I always, or if I can, if the animal doesn't have a really low albumin, for instance, then I don't go for probiotics. But otherwise, I always try a multi-strain probiotic before we go to endoscopy, because as Fabio says, some animals respond to it. It's really difficult to know beforehand which will respond to it. But if they do respond to it, it's really nice if we don't have to give anything stronger than the probiotic.
Mm-hmm.
Agreed. And there's evidence in the literature to support that, especially with IBD patients for multi-strain high-dose probiotics. So definitely, if I get this question a lot of like, should I pick single agent versus multi-strain? And a lot of times I am reaching for the multi-strain. And some of that is just because I don't have evidence for the single strain in certain chronic enteropathy cases. Not to say that it won't work. I do have some patients that respond. But the evidence right now lies in the high dose multi-strain. And I think too, like something to think about is, each individual animal's dysbiosis might not be the same, even though they have the same chronic enteropathy. So just because I have one that responds to, brand X probiotic and another one who doesn't, can be really challenging because it is so patient specific. So I do think that as a clinician, we do have to keep an open mind to that. I try the best I can to practice evidence-based medicine and use treatments that I know have been, shown to have efficacy, but just because my patient doesn't respond, to one doesn't mean that they won't respond to a different probiotic. So I think we have to keep an open mind there because there are a lot of different probiotics on the market.
Mm-hmm.
Yeah, and that's very good. And I really wonder, what are the criteria when you choose a probiotic, or what would you advise to look at? As you said, there are many different probiotics.
Yeah, I mean, I think for me, just because I do try to focus on the evidence-based piece, the type of probiotic that's shown the best response for chronic enteropathy IBD is high-dose multi-strain right now. And so that's what I'm reaching for. I don't know if the others want to comment, but, a lot of times owners balk at the cost of those, which also can sometimes be an issue. But I think, that's where the evidence lies right now.
Mm-hmm. We need to only have a few minutes left. At what point, and Fabio, maybe a question. So in your case, you decided to do FMT before reaching to steroids. How do you guys see the future where FMT is going to fit into the sequential treatment approach of CE?
Yeah, no, that's a very good question. Actually, I tried to answer. It's been a while since I've been thinking as well about where to place FMT, since once the evidence was starting to come out. And we actually did a small study, which we're hoping to present at the next European Internal Medicine Congress in Barcelona, where we actually decided to act with FMT after the diet trial. And so we took some dogs which did not respond to either to an elimination diet trial of 2 weeks duration, so whether it was a single novel protein or a hydrolyzed diet. And then we acted with FMT, and a very high proportion of these diet refractory cases went into remission with 1 to 2 FMTs. And we have some long-term data where actually you can see that was enough to resolve clinical signs without the need of repeating FMT. And of some of these cases, we actually have 6 months, even longer follow-up data, and a good proportion of these dogs is still in clinical remission with the single FMT protocol. So,
but still on the same diet, correct? They're still
without changing the diets, because obviously we wanted to leave everything as stable as possible, so introduce bias. But obviously, the question mark.
But just to clarify, it was not the original diet; it was still a dietary new diet, correct?
Yes.
Either hydrolyzed or home cooked. So FMT was on top of that.
Yes.
Okay.
So first the diet change, either home cooked or hydrolyzed. Then if they didn't respond in terms of the clinical score, the CBDI, we then proceeded with FMT. Mm-hmm. And of course, you could ask yourself and say, are you sure they improved for the FMT, or it wasn't just giving longer time to the diet to work? But we don't have the answer. But the truth is, FMT could be the second sequential option right after diet. So that's in young dogs, because our cohort was, the majority of these dogs were young, and they had a mild clinical score, so not very severe, like some of Linda's cases where the disease was very chronic and they were already receiving immunosuppressive. So perhaps that's the patient's identikit. So young, early stage,
less dysbiosis, less changes on the mucosal level. Yes, perfect.
Yes.
So I think a few questions. Obviously, FMT is going to be where I think Janessa, probably only you can just mention that there's going to be a consortium coming out with guidelines, correct?
Yeah. So in a couple months, it should be available and in press. So the consortium has been working for a year and a half to put together guidelines for practitioners to approach FMT in practice. So it's going to walk through 3 major sections. So it includes donor screening, and it has recommendations for who to include, who not to include, and what testing would need to be done or recommended. There's kind of different levels of testing that will be included. We also have a section on how to collect the feces, process the feces, and it's at all different stages. So depending on what your practice has as far as availability of freezer space and things like that, we have a lot of options to make it more practical. And then the last section is really going to focus on administration, where we have the evidence right now and where we see it going in the future. So again, these guidelines are going to be set up to really be practice ready. We are trying to make them as friendly as possible for veterinarians to be able to incorporate FMT and having a fecal bank or fecal donors within your practice, so that you have accessibility to this novel microbial therapeutic.
One final question, maybe. We know that antibiotics have a negative impact on the microbiome. Most antibiotics, long-lasting. Any news about any information about steroid administration?
Steroids after an antibiotic?
No, sorry. Well, how does steroids affect the microbiome?
Oh, gotcha.
Yeah.
Okay. Yeah. There is a nice study from Rachel Pilla, and Jan is involved in that study too, that shows that dogs responding to steroids can have a almost normalization of the microbiota, so decreased dysbiosis after the use of steroids. So I guess that's because it would suppress the inflammation, and those were steroid responsive dogs, and that had a positive impact on the microbiome. So we don't have to be afraid to use steroids that we will damage the microbiota.
Perfect. And again, it shows you probably this interaction between mucosal level and dysbiosis. All both go hand in hand, and some of them you can use them as a marker of improvement of the GI structure. But once again, those are together, I think it just shows you they can amplify themselves. But ultimately, we need to understand the microbiome can be a marker of a disease, but it also can contribute to the disease. So I think, like with every other marker, correct? Perfect. I think we're almost at the end of our session. Thank you so much, all. I think we had this idea that maybe each of you gets a little bit like 3 highlights or 3 important things to remember for everybody. So that's what would you, each of you would, in 3 kind of key points, what would you like the audience to take home? I'll start with Linda. Yeah.
So we have discussed things that maybe aren't evidence-based yet, like mycophenolate. I hope to present a study on that later on, when I spend 1 year at Jan's lab and I have a lot of time to write and less time to see patients. But go for the evidence-based treatment first. So start with diet and try several diets if you can, but don't go for the antibiotics. So that's number 2. Avoid the trial of antibiotic. Use antibiotics as your last resort. And number 3 to me is that the evidence to use fecal microbiota transplantation in dogs with chronic enteropathies is increasing, and I think you should consider that at an early stage if you can and have the possibility. And in the paper that you will soon be able to find online, we did have some dogs that couldn't be without antibiotics, but after we treated them with FMT, we could stop the antibiotics. So that's my 3 take-home messages.
Janessa?
I think my first is the owner expectations. I think having those open conversations right away are really critical in this. I think it sets up a good relationship for you and with the clients. I think 2 for me is I'm reaching for fiber much sooner in these patients. And so that would be one of the first things that I'll be considering and looking at. And then number 3 for me is based on the evidence that's building for FMT. I used to use it at the end of my, as a last resort, and I'm incorporating it much sooner. And so I think that we need to start having conversations about microbial directed therapeutics such as FMT much sooner in these cases.
Julia, I'm sure I know what you're going to say. All
well,
3 key points.
I only have 2 left, as Janessa already mentioned, the fiber one, which of course would one important point for me too. But I think it's really worth to look closer to the diets in patients who have difficulties to handle them, and maybe also before you start large diagnostics and therapies and all this stuff. So I think this is really important to consider, that diet is very diverse as well, and digestibility can be crucial. We know this as well. So fiber, digestibility, and diet itself in detail would be my 3 important points.
Fabio?
Right. So my take-home message is, first one, so chronic enteropathies are a very diverse group of diseases or syndromes. So they know all the same, so and clinical signs overlap. So for me, the easiest way of approaching them is a sequential treatment trial rather than for every case multimodal therapy, especially if clinical signs are mild and the patients are young. And so hold off antibiotics, steroids until you have tried less, let's say, invasive trials first. So diet. And then my second point is FMT can actually be a very great treatment options to try for food refractory cases. We have some evidence from our study, again, especially in young animals or animals that actually have used antibiotics. So I think FMT is a really good option to consider. And the final take-home message is, don't use antibiotics unless you have real strong evidence that what the clinical signs are due to an infectious cause. In this case, like a bacterial granulomatous colitis, but those cases are honestly very, very few. So
perfect. Well, thank you so much, Natalia. Do you have some final words?
Yeah, thank you very much. And it was really great discussion. I hope that everyone who was listening that got a lot of messages for the practical work. And I would like to share some slide, because this is important for our audience. Everybody will see that this roundtable discussion will be available on demand. Please advise to your colleagues who could not come on time of live event. You will receive the certificates with the CE credits approved by RACE. For those who will watch on demand, they will receive also a certificate, but without CE credits. But what I would like to say, if some of you not yet registered to the Purina Institute, please sign up, because you will be the first one to be advised about other events of Purina Institute. And the next one is coming, will be evidence-based selection of supplements in clinical practice. And also for those one who will sign up for the Purina Institute communication, you can get an ebook on small animal nutrition that is very, very useful for clinical practice. And then again, thank you very much for everyone, because together we really can put the power of nutrition science into practice. And I wish all to you all the best. Thank you very much.
At the Purina Institute, we transform nutrition science into actionable information that you can put into practice to benefit your patients. Our extensive resources help equip veterinary professionals with unbiased, science-based information to help you build on your nutrition expertise. Together, we can put the power of nutrition science into practice and help pets live better, longer lives.